Hello, welcome to your online lecture for the basics of managing athletic injuries. Today we're going to be talking about inflammation and the phases of healing, and how inflammation plays a positive role in patient healing, and how it can also be negative or deleterious to our patients if we don't control it, if we don't intervene. So we will have a fully online week this week in care and prevention. You'll have an exam due, which will cover weeks 1 through 5 in the course, and then you'll have this online lecture with quiz questions embedded throughout. And again, this is a really important lecture because it builds the pathway for us to be able to understand how an injury heals, and then also to allow us to recognize when an injury actually has occurred. So the first stop is inflammation. Anytime I say inflammation, I feel like people cringe and kind of think of inflammation as a negative response to injury, but believe it or not, it's a very positive response to injury if it's controlled. In fact, we know that inflammation is absolutely a necessary process that helps us accomplish the process of tissue healing, and is needed in order to return our patients to normal function. Essentially, what we get with inflammation is this immune response. It triggers the white blood cells to be released to start the process of phagocytosis, or the process of eating away all of the dead debris in the area so the patient can begin the process of healing. So it's absolutely important and necessary, but we as healthcare practitioners have to do everything we can to create an optimal environment for the patient to heal. It's when we don't work to control inflammation and when we don't use our skills to help the patient after an injury that we see inflammation can take on a chronic effect and have a negative impact on the healing process. I do want to stop and say that oftentimes I hear students saying, oh, we can speed up the healing process. The reality is we can't do anything. There isn't anything in our toolbox that we can do to speed up the healing process, right? An injured bone is an injured bone. A fracture in the bone is a fracture in the bone, and that bone needs time to heal. And that's a physiological process that we can do nothing about. Same thing, if we have a torn tissue, we can't speed up the rate at which that tissue is healing. What we can do for both of those injuries is really create this optimal environment. And so what does that look like from a healthcare professional standpoint? If you're an athletic trainer or a physical therapist, even an occupational therapist, your role is going to be to come alongside that patient to evaluate the injury, to maybe apply different modalities such as ice or massage or electrical stimulation to help kind of reduce some of the signs and symptoms that are associated with the inflammatory response, right? If you're a physician assistant or even a physician, one of the things you might be asking is, well, I don't really have that role in the healing process, but you play a major role. You can prescribe anti-inflammatory medications, right? You can identify the injury and refer them out to your therapist, right? A surgeon can maybe perform a surgical technique which would create an optimal environment for the patient to heal. But ultimately, our major role is to create, or the creation of an optimal environment for the patient to actually heal over time and to allow that tissue or that bone enough time to really restore itself back to normal function. So with any inflammatory response, what we have most often are the cardinal signs of inflammation. And I won't spend time defining them here because in the next few slides, I'll provide a definition and then tell you what physiological response is actually happening to cause heat or redness or swelling or pain and even loss of function in our patient. But these signs are key because they are what alerts us to the fact that we actually have an injured anatomical structure, right? It allows the athlete or the patient to withdraw from the athletic setting or the work setting, right? And to come see us so we can then further evaluate them. So the cardinal signs of inflammation, the top two are pretty much interrelated in that when we have a red area that isn't associated with infection, right? If we have a red area following an injury, let's say it's an ankle sprain, the ankle is red. Most often that's as a result of histamine. And histamine, when it's released, it causes a vasodilation, which ultimately causes an increase in blood flow. So we can see how the two are interrelated. And that increase in blood flow will naturally make the patient's skin appear to be red. What it also does is it increases the heat in the area. Another reason that we see a warm joint after injury is going to be an increase in cellular metabolic rate. So our cells are working harder to restore, to provide restoration to the injured area. And so that collision that's occurring between the cells creates heat in the injured area. Again, irrespective of infection, right? These are just natural processes that are occurring as a result of the inflammatory response. We also have swelling, which occurs within the joint. Swelling is a great indicator that there's injury, but I do want to say that not every patient that has an injury will swell. So we can certainly look for swelling in the injured area, but not with every patient will we see a swollen, injured area. Swelling occurs as a result of really two components. Number one, we have a tearing or an injured anatomical structure, and that swelling cannot stay in the area, and so it kind of will spill out into what we call is the interstitial space, and that happens as a result of physiological chemical mediators that are released. One such chemical mediator that we'll talk about a little bit later is going to be prostaglandin. What it does is it kind of increases cellular permeability, making the cells more, what's the right word? Making it easier for fluid to leave the cell and move into the tissue, and that's how we get that swollen joint. And so then we have pain, and pain can really result from two key mechanisms. Either we have chemical irritants that are released, or we have mechanical pressure. And so the chemical irritants will bind to what we call our nociceptors or pain receptors and cause a painful response, trigger them to cause a painful response. Or the swelling above us that has been caused because we have this increase in cellular permeability, and we allow the swelling to move out into the interstitial space. That swelling will then start to press on those nociceptors and trigger them to fire, causing a painful episode. And those are treated differently, right? If it's a mechanical pressure, we can massage and hopefully move that swelling out of the area. If it's a chemical irritant causing that, then most often that's usually some type of pharmacological intervention, some type of prescription most often, which will reduce the amount of circulating chemical irritants to relieve those nociceptors, right? And then we have loss of function, which tends to be linked to pain and swelling. Most often, if there's pain in the joint, the patient won't want to use it. They'll guard and they'll protect themselves. If there's a swollen joint, the joint won't be as functional, won't have as much range of motion, and so as a result, we lose function. Loss of function, some see that as a negative effect in the earlier phases of inflammation, but I actually see it as a positive effect, because when they lose function, they'll use the joint less, and so that means there's less damage to the tissue occurring in the earlier phases of the inflammatory response. So it's very protective in nature. So the phases of healing that we're going to talk about are the response phase or the inflammatory phase, the repair phase or the proliferation phase, the remodeling phase or the maturation phase. And what I want you to see from this slide is that each of these occurs on a continuum. And what do I mean by that? If we look at the inflammatory phase, which has been projected to last about 1 to 4 days, we look at the repair phase, which has been projected to last about 72 hours to 3 weeks, and we look at the maturation phase, it's been projected to last about 3 weeks to a year. We can see that there's overlap in each of these phases, right? And that's intentional, because every patient is so unique and distinct and different that their phases may look different, or their phases may shift. In other words, that inflammatory phase may last a little bit longer or may be shorter, right? That's why it's important as clinicians that we really don't compare healing times for patients, because every patient is just so unique and so distinct. So here it is again, the healing process on a continuum. So let's talk about the first phase, which is the inflammatory phase. I like to call it the attack phase. It lasts from the initial insult of the injury until about day 4, but certainly can go longer depending on what that patient's doing. Do they withdraw from the event or practice or work, or do they continue to do that? It may extend the time of this phase if they are continuing to participate in the event. So when we think about the inflammatory phase or the inflammatory response phase, what we're thinking about is this is a phase that's going to be triggered by some type of injury or chemical irritant or bacterial infection, right? Or heat. It's the initial insult, right? It's the thing that causes the patient to come see us, right? Most often, this inflammation is going to be triggered by those things, right? And then it can last anywhere from 3 days, and we call that acute inflammation, 4 weeks, we call that subacute, and anything after that 4 weeks, we call that chronic inflammation. And chronic inflammation is very difficult to treat. So we really want to make sure that we're creating that optimal healing environment for that patient to heal, so that we don't create a chronic pathology or a chronic type of inflammation. So in the initial phase, in the acute phase or the inflammatory response phase of the injury, that trauma that's created, that chemical trauma, that physical trauma or mechanical trauma, that bacterial trauma, whatever it might be, creates what we call our 2 different types of injury. The first injury is the primary injury. The second injury is the secondary injury. The primary injury, and when we think about it from a treatment perspective, is something we can do nothing about. In other words, it is the initial incident. It's the inversion that happens that causes the tearing of the ligaments, or the hyperextension moment that causes the rupturing of the PCL in the knee. We can do nothing about that, right? Because that's the point at which the patient falls onto the field or falls onto the floor, and everything starts to ignite or starts to happen. This primary injury is most often represented by a hemorrhage or an influx, or an escape of blood through the tissues into the injured site. And then what we start to see is damaged cells, or cells that start to begin to die off after the actual injury, right? And those cells would be the muscle or the tendon or the ligament or the bone that's actually injured, right? That's the primary injury. We can't do anything about that. That happens the moment the injury occurs. But what we can do something about is everything that happens from that moment on, the moment the athlete or the patient comes into the clinical setting to see us, right? And that's the secondary injury. What we know about the secondary injury, and I think on the next slide I'll progress to that, we have this vasoconstriction moment that occurs where we're walling off the injury and we can't get any oxygen, we can't get any new blood into the area during that time. And so it creates a hypoxic, lack of oxygen environment. And so then cells start to die off. And so that's where we can intervene. Like, how do we increase blood flow to that area? How do we get more oxygen into that area? How do we begin the process, or how do we stimulate the process of phagocytosis to occur? From a macroscopic view, this is what I just said, right? We have this immediate vasoconstriction that lasts about 10 minutes, give or take, and there's a reduction in the amount of oxygen or hypoxia that occurs. And so as a result, the cells start to die off. But after that 10 minutes, right, after that 10 minutes, what we see is the release in histamine, go back to the cardinal signs of inflammation. And so we get this increase in new blood into the area. And that's good and bad, right? The good part of that is we get an increase in blood flow, which means we're bringing in more oxygen. Now cells are allowed, particularly the white blood cells, are allowed to come into the area and start the process of phagocytosis. And then in some regards, that can be negative, because now that we have this influx of blood, we also see that the joint becomes a little bit larger. In other words, we have swelling that starts to occur. But the great thing about the new blood, in addition to oxygen being there, is now we have a wall being formed off, or a hematoma begins to form, and it begins to seal off the injury so that healing can actually occur. I've mentioned oftentimes that there are these inflammatory agents. There are 3 major inflammatory agents that play a major role in the inflammation process. Prostaglandin and serotonin are responsible for increasing what we call a cell permeability. And so what's that mean? It means that fluid can leave the cell and then go into the interstitial space, creating swelling in that particular joint, right? So we have this leakage of fluid out of the cell into the tissues, and so that's where we get swelling from occurring. And then we know what histamine does, right? Increase in histamine, there's vasodilation that occurs, and then what we have with that increase in vasodilation is increase in heat and maybe some redness that starts to occur. But then certainly we have with that an influx of oxygen into the injured area. As we move forward, the great thing about the vasodilation is what it brings with it, right? It's going to bring in the leukocytes, which are going to kind of begin to fight off and begin to eat away all of the dead cells in the area. And then we get these macrophages. One of the white blood cells that infiltrates the injured area are macrophages. And the great thing about macrophages is they can live in a very low oxygenated environment, so they don't die very easily. And we love that about them, right? Because initially, remember, after that 10 minutes, they're coming into a very low oxygenated environment because it's been walled off, or there's been this vasoconstriction moment. So they can survive and they can thrive in that low oxygenated area, and they can start to kind of clean away the dead cells until the neutrophils and the monocytes, which can't always thrive in a low oxygenated area, begin to infiltrate and come alongside those macrophages to help with the process of phagocytosis. So this process right here is one of the things that really is exciting about the inflammatory phase. It's where we start to clean away all of the dead cells, and it's going to be responsible for triggering the proliferation phase, which is the next phase. Phase 2 is the proliferation phase. Proliferation phase begins at about 72 hours and will go about 3 weeks, okay? Proliferation phase, or the repair phase, as the name implies, is going to be the process of repairing the damaged tissue, right? And I get excited here. This is where the patient is more functional. So they have a decline in a lot of those cardinal signs and symptoms, a decline in pain, a decline in inflammation, and so they're beginning to feel more functional in nature. So the proliferation phase, or the repair phase, is most often from an external perspective. If we have a wound, we'll start to see a scar. But if the injury occurs internally to tissue, to bone, what we'll start to see is new tissue kind of laying down if we were to look at it from maybe an MR perspective, right? So what we see in the repair phase is the wound is going to be repaired. That wound is prepared through the process of collagen synthesis, or the laying down of new collagen in that area, through the process of fibroplasia, which is this concept of the blood clot becoming more mature, forming a scar, and then revascularization, or kind of restoring of blood vessels that were damaged or injured in the actual initial injury. So what we see over time with wound contraction, and this is a scar, but it certainly happens internally too, is we start with something that looks very wide, and then over time we start to see how the wound closes. Does that make sense? Or how it starts to realign, or how the collagen starts to lay down and kind of bring the wound or the ends of the wound together. And so initially, the scary part about the repair phase is initially that collagen is very, very weak and has an increased risk of re-injury. And so we have to be careful in the earlier phases of the proliferation phase to not stress that joint or that injured tissue too much, because the collagen just isn't like the original tissue to begin with, right? The scary part about the proliferation phase, however, is because a lot of those cardinal signs and symptoms are starting to decline, the patient gets more function, and so they start to feel better and they want to do more, right? But you guys will know, you're educated healthcare practitioners, you'll say, slow down. We're still in the repair phase where we're laying down type 3 collagen, which is extremely weak and hasn't had a chance to align straight enough to withstand the forces and the stresses. So we're at the highest risk for re-injury in this phase of injury, or in this phase of healing. So we have to be very, 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 very careful. So at about week 3 up until a year, and yes, healing can take up until a year. Let's think about like ACL, PCL repairs, for example, labral repairs. I'm just giving a few sports medicine examples. We'll enter into what we call as phase 3, or the maturation phase or remodeling phase. This is when you have that type 3 weak collagen kind of transitioning into what we call as a type 1 collagen. It becomes stronger, it's more aligned, and it can withstand the stresses and the demands that are going to be placed on it. And at this point, it's where the collagen really tries to replicate the original tissue. The reality is, though, that most often the replacement tissue is never as strong as the original tissue. So in the maturation or remodeling phase, I don't know about you, but as an athletic trainer, as a physical therapist, as an occupational therapist, as a conditioning strength coach or sports scientist, you should be getting pumped at this phase, because this is the phase where we start to do more transition to sport, transition to activity, return to work activities, so more sport specific work like activities. And this is where your athlete starts to get a little bit more excited, because by then most of the cardinal symptoms are gone. And so now they can actually load the joint or the muscle or the bone. They can get back to or resume, we'll say, a normative state, obviously with some restrictions. But here is where the collagen matures. There's an increase in strength of the matrix, and so we can go at it in our rehab. We can bring it in our rehab, and we're not concerned with re-injury like we are in the proliferation phase. And I want to say here, I'm not saying we shouldn't do exercises in the proliferation phase. I think that we should maximize the said principles, specific adaptations to imposed demands, allowing our patient's signs and symptoms to drive or dictate what we do and how we progress them is honestly the hallmark sign of a great clinician overall. Okay, I said this in the other slide, and I'll say it here again, that the new tissue is going to be very similar, but it's never going to be identical in terms of its tensile strength to the original tissue, and it's most often going to be weaker. So what we want to do is really not only strengthen the injured area, but strengthen the anatomical structures around it to support this more weaker tissue per se. Does that make sense, everyone? I really truly do hope that makes sense to you all. Okay, I'm going to give you some general tissue healing and collagen synthesis times. Again, every patient is a little bit different, but here are some of the kind of hallmark healing times for muscle. You have about 3 to 4 weeks for tissue healing to occur. But if, depending on the tear or the degree of the injury, it may take 60 days for it to regain normal structure and function, for that type 1 collagen, that strong collagen, to kind of lay down. Is it is a light bulb going off? Are you thinking, that's probably part of the reason that we see a lot of repeat hamstring strains, for example, in track and field, as an example, right? Or repeat strains in general, because yes, they take 3 to 4 weeks to heal themselves. But if we're looking at proliferation phase and maturation phase, it may take 2 months for the muscle to be back to like full function. Here's the inherent reality though, you guys, right? The inherent reality is sometimes when an athlete or a patient is in the middle of season, we don't have the 60 days. So we take those 3 to 4 weeks, we maximize the best that we can, we create the optimal healing environment, we return to play, we make sure those cardinal symptoms, sign symptoms are reduced. But in off season, we have the 60 days, right? So we have to take it as a seasonal approach. Where are they? Are they in preseason? Are they off season? Are they in season? That will also help to drive your decision making. Tendon and ligament, however, take a little bit longer to heal themselves. And what's the reason for that? Good. All of you said, hopefully, that they get less blood flow, right? Muscle, we've got capillaries, arteries, veins, so much blood flow going to muscles, right? So the healing, because we can get more blood flow, more oxygen, healing occurs a little bit quicker. Our tendons and our ligaments, however, have less blood flow. So they take a little bit longer to realign and to heal themselves, because it takes a little bit longer to get oxygen there that they need to thrive and survive, right? But there are key factors that determine the healing time. It's going to be the extent or the degree of the tissue damage. So was it a grade 1, grade 2, grade 3, right? The vascularity of the area, we just talked about that with muscle versus tendon and ligament, and the age of the patient. Well, so I'm not going to say how old I am, but let's just say it takes a lot longer for me to recover from an injury than when I was 18 or 19. So appreciate your young bodies now, because younger patients tend to be more resilient. Okay, did I just say that well? They tend to be more resilient and take less time to recover. But part of that is because they can recover quicker. All right. So what is our role in terms of injury management? If you're a PT, an OT, or an AT, right? Or even a strength and conditioning coach or personal trainer, I think ultimately it's creating effective rehab programs, right? And that rehab program is going to be all-encompassing and include treatment. So what are you doing to control the swelling? What are you doing to reduce the cardinal signs and symptoms? I'm not going to go through this whole entire list, but what are you doing to reduce the cardinal signs and symptoms? And are you doing that early on, right? In that acute inflammatory phase before that swelling becomes chronic? Everybody's seeing that? We're going to restore strength, not just to the injured area, but to the structures surrounding the injured area. That's a big key component to returning a patient to work or to play, is making sure that we not just focus in on the injured area, but the areas that surround it and have had to support that injured area while it was injured. We want to reestablish what we call as neuromuscular control and or balance within a particular joint. And then one of the reasons we see increase in injury upon return to sport has to do with the lack of cardiovascular fitness and activity that we do in our rehab protocol. So we need to integrate cardiovascular fitness and figure out what that looks like for an injured patient. So an example of that might be, if I have an injury in the lower extremity and we don't want them to load on the ground, let's put them in, an ultragravity treadmill situation or in a pool and have them jog, or use the upper body ergometer to just keep the cardiovascular fitness up. Because by the time they return to play, if they aren't fit, then the risk of injury is increased either way that we look at it. So immediate interventions that can be used ultimately to treat patients following an injury. Here's the old acronym, PRICE. So protection, rest, ice, compression, elevation. Let's talk through those quickly. When we think about protection, when I went through an undergraduate curriculum, we didn't really have the P in there. It was just RICE, right? But the P is actually most important in an injury. And the reason for that is because we want to protect the joint in the acute phase when what's happening, the process of phagocytosis is happening, right? The process of walling off the injury is happening. We also know that the tissues are the weakest in this area, right? That area and proliferation phase. So we want to protect it. What does protection look like? It's going to depend. It's going to be a walking boot if it's upper extremity or lower extremity. It's going to be crutches maybe. Remember I talked about putting them in some type of sling or a splint. Want to really protect that joint when they're not in rehab with us. The other, which I think goes with protection, is resting. So resting the joint when we can. Again, we can use the same things that we use to protect to rest. And then we can ice. So there is some research out there to suggest that icing early on, it has deleterious or negative effects. So what I'm going to say to you is that we know that ice helps reduce pain. And so one of the things that we can do is ice to reduce the pain, right? So to reduce that pain, spasm, pain cycle. If we reduce pain, we reduce hopefully the loss of function that patient is experiencing. And then compression is always great. And so here are some, the Game Ready, we have recovery boots now. The compression is great because it pushes out any inflammation or swelling that occurs because we have the increase in prostaglandins, and we have fluid leaking out of the cells into the interstitial space, and so it will help reduce the amount of swelling and assist the lymph system. And then elevation, in this bottom right hand corner, is ideal. Again, if you want to assist the lymph system, putting the joint at a 90-degree angle is the ideal. So we can take this price intervention and use it very early on to kind of help reduce a lot of the cardinal signs and symptoms, and hopefully reduce the symptoms coming out of that inflammatory phase of healing. That is all I have for you guys. I hope this was helpful. I hope you understand what the body goes through physiologically once an injury occurs, and how you can come alongside the athlete to create the optimal healing environment.